is Matthew Castelluccio. I am the VP of Community Support for United Spinal Association. Many of you were contacted by me inviting you here, or your hospitals, where most of you are part of the hospital membership network. It's one of the programs I oversee and I really value greatly, because I feel like through empowering you guys through education, resources, and support systems, it helps trickle down to that individual that you're serving, so that when they leave you guys, that they have the support systems to be successful through the journey of recovery in life. All right, so I'd like to thank you for taking the time out of your busy schedules to come here, and for your administration for supporting that. The United Spinal recognizes the value of creating an opportunity for engagement between professionals, community members, and corporate partners. And that's kind of the theme of this weekend, right? Bringing all parties together. So I hope you guys will take advantage of networking and engaging each other, as well as the community members and the corporate sponsors. This weekend, we have 3 professional workshops scheduled focusing on accessing equitable healthcare. So please use those opportunities to share resources, share input on programming and services. Before we get started, I'd like to just acknowledge a few special guests that have joined us for this event. We are pleased to have 2 members of our United Spinal Medical and Scientific Advisory Committee, Dr. Christine Sang and Downey Henricks. And we also have the founder of the North American Spinal Cord Injury Consortium, Jennifer French. I think Jen's in the room right there. And is Downey here in the room? Yeah, there you are, right there. And Dr. Sang is not here. She's joining us. So please take time this weekend to speak with them about their programs and learn more about it. They're both very important programs that help us to do what we do as a national organization. So we will be starting off with a workshop that directly pertains to the current medical environment we live in. COVID has changed the approach to healthcare significantly. So I am pleased to introduce the facilitators of our first workshop, titled Using Technology to Achieve Health Equity for Wheelchair Users. Our VP of Technology and Innovation, Brooke Ellison, and our Director of Tech Access Initiative, Louis Lineberger. So I now will turn the mic over to you guys.
Thanks, Matt, and welcome everyone to the first annual United Spinal discussion on disability, technology, and human rights. Today's panel will focus on how technology can be the mechanism by which healthcare access and healthcare equity are better achieved for people with disabilities. We have quite a diverse and esteemed group of panelists here today, and I'd like them each to give a very brief introduction. We have Brianna Gilmore from Uber, John Branch from My Laurel Health, Kai Wong from Teladoc, and Randy Trumbauer from Spalding Harvard. So Brianna, we can start with you.
Hi, good morning, everybody. I'm Brianna Gilmore. I work as the head of accessibility in underserved communities at Uber. I've been a disability advocate for the past 12 years, and I currently live in Baltimore.
Great, thanks, Brianna. John, if you'd like to go next.
Yeah, absolutely, and thanks for having me. John Branch. So I've spent about 20 years in healthcare, in particular healthcare IT, and over the past 10 years spending time in how do we think about technology and services and bringing it directly to where the patients are in the home. So I work for My Laurel Health today, leading that team. Prior to that, I was with Best Buy Health and trying to bring together remote patient monitoring technology along with Geek Squad and everything you would Best Buy into the home to make it accessible for all patients. And I'm in Florida.
Great, thanks, John. And Kai, we'll go to you next.
Hi, everyone. I'm Kai Wong, tuning in live from Washington, D.C. I am the Senior Manager of Digital Accessibility at Teladoc Health, where I lead our engineering and delivery teams for web and mobile accessibility. And I'm extremely passionate about accessibility and the disability community. It definitely holds a very special place in my heart, and very excited to be here. Thank you.
Great. Thank you, Kai. And Randy, you're up.
Yes, good afternoon, good morning, wherever you're from. I just want to say, first and foremost, thank you, Matt, Brooke, Lewis, and the entire United Spinal Association and the Tech Access team for inviting me to participate in this, what I think to be a very timely and very important session on assistive technology. And I'm grateful to have this opportunity. I'm an associate professor at Harvard Medical School and also the executive director of the Travis Roy Center for Enhancing Independence at Spalding Rehab Hospital in Boston, Massachusetts, where we are dedicated to helping people restore functional independence and autonomy after injuries or disease that have resulted in tetraplegia or paralysis. I spent the last 25 years dedicated to this mission, and so I'm looking forward to sharing some of my perspectives and experiences with you today.
Great. Thanks, Randy. And with that, I'll turn it over to Brooke Ellison, who will be facilitating today's conversation. So Brooke, the floor is yours.
So thank you so much, Lewis. Thank you for the introduction. Thank you, Matt, for manning things there on the floor. You guys have done an incredible job, and I appreciate all of this so much. So I've lived with quadriplegia for now 33 years, so the vast majority of my life, and I have seen on an increasing basis the role that technology has played in my life and the lives of so many other people. With disabilities in general, wheelchair users in specific, how it helps to create enablement and gives them avenues to pursue life and quality of life in ways that they may never have imagined possible in the past. So having panels like these and conversations like these, I think, highlights that very idea. And that's why I'm so excited to bring this conversation to all of you and to share it with you. And this panel is composed of people I either have known for a while or have come to know over the course of this past year. And they are brilliant, thoughtful, really important voices in an important conversation. So what we're going to do is we're going to spend the first hour or so talking and some prepared questions, and then we'll take a break, hopefully at the top of the hour or thereabout, and then come back and finish the program. And then we'll reserve some time at the end for questions from the audience. I can't see you, so Lewis and Matt are going to do the question facilitation from the floor. So thank you, you guys, for that. And just before we start, we're just going to kind of lay the groundwork so everybody's kind of operating from the same starting point when it comes to some terminology. So when we're talking about assistive technology, we're going to be talking about those pieces of equipment or items or software programs or products that are being used to either increase, maintain, or improve the functional capabilities of somebody with a disability. And that can be either high tech or low tech. And we're talking about accessibility, we're talking about the design of products, devices, and services, and vehicles or environments so as to be usable for everyone. And this is particularly the case for people with disabilities. When we're talking about telehealth platforms, we're talking about the ways in which you can interact with your healthcare providers outside of an in-office encounter. And they are often conducted online through internet access and have been used with increasing regularity since the pandemic. Social determinants of health is a term you may have heard, particularly over the past several years. So according to the CDC, social determinants of health are the non-medical factors that influence health outcomes, such as poverty or unequal access to healthcare, transportation, social stigma, education, racism, all of these things that impact our health in really important ways, but are not necessarily directly related to health. And then health disparities, and thus the differences in healthcare status or outcomes that affect different populations in disproportionate ways. And then finally, health equity, which is what we're hoping to achieve through conversations like this. So health equity is a state in which everyone has a fair and just opportunity to attain the highest level of health. So that's just kind of the starting point. So we all know what we're talking about. We're not using jargon or language that people are not familiar with. All right, so let's jump right into it then. So let's start by giving everyone a sense of where the current intersections between technology and healthcare exist right now. So Kai, could you start by telling us a little bit about telehealth platforms and what they are and how they've been useful, particularly over the past several years, and particularly for people with disabilities?
Yeah, absolutely. Thanks, Brooke, for the question. And telehealth has been absolutely game changing. I would say, especially in the pandemic when it just wasn't safe for anyone to go out into the public and be interacting, especially in doctors' offices where the germs are just flying everywhere. So telehealth being an option for getting virtual care, not having to leave the house has been absolutely game changing. It also removes one of those largest barriers for care for people with disabilities, which is transportation. You can just literally log on to a platform virtually using your phone or a computer and get the care you need that way. And a lot of people did try telehealth for the first time during the pandemic. So we did see a significant increase during that time.
Great thing. And just to follow that up, so what have been some of the challenges that healthcare technology companies have faced or are continuing to face when it comes to accessibility?
Sure. Yeah, accessibility in healthcare companies, especially healthcare technology companies, it's multi-layered. It's not just thinking about making sure that there is equitable access to healthcare. It's also making sure that those experiences and outcomes are also equitable. And it is requiring collaboration between different types of experts who have historically not worked together. Think about the doctors, right? And engineers or software engineers specifically. In the past, that hasn't really been an overlapping field. And now it is requiring for this type of collaboration to take place. So there's a little bit of friction, a little bit of learning to be had there for sure. And then on the technology side, I would say there are definitely challenges for ensuring accessibility. I would like to highlight at least three of them. Number one being that technology changes extremely fast. It could be thousands of lines of code getting pushed out into the world on a daily basis, sometimes weekly basis, and accessibility teams and engineers, quality engineers, having to keep up with that very fast-paced technology is not easy. Sometimes there's a lot of different teams that are working on the same experience or a specific part of a website, and those code changes can conflict with one another. So there's a lot of moving parts, and on top of that, just the speed is quite a force itself. Next would be accessibility is tested through manual and automated testing, especially support with assistive technologies. So the fact that it's automated and manual, it does make it a challenge to monitor at scale. So if you think about a technology platform that it has 30,000 pages, for example, it's not going to be easy to monitor or test every single one of those pages and keep up with the changes that are going out. And then lastly, embedding accessibility requirements throughout the software development lifecycle. That's going from the product organization, the designers, from product managers to designers, then to development, and then to QA, and then being released. There's a lot of processes already in place. So embedding accessibility throughout all of those, it's not a quick or easy project. And it does require typically a culture shift that needs leadership buy-in and funding support. We need process changes. We need complex monitoring abilities, and at times buying new tools and more. So there is just a lot to happen for accessibility within healthcare technology. Not to say it is not important, because it certainly is.
Yeah, thank you for that, Kai. I think some of the points that you raised are going to intersect perfectly with some of the conversation that we're going to have after the questions, after kind of the formal questions, when it comes to how to ensure engagement, how to ensure that level of accessibility through every step of the innovation process, right? It's not easy, but it's so critically important. Otherwise, we end up with technology that's not usable or not well designed or not as well designed as it could be, especially when it comes to people with disabilities. So I'd like to turn a bit from telehealth platforms. So they've really been kind of the bread and butter for a lot of technology when it comes to healthcare. It's often what most people are most familiar with and the kind of the most widely used technology when it comes to healthcare for most people. But particularly those who face different kinds of chronic or challenging healthcare conditions, like many wheelchair users do, there might be need for more extensive technological interventions. So, John, I'd like to turn to you for a second. Can you tell us a little bit about some of the work that you do in remote patient monitoring systems and what that's all about?
Yeah, happy to. And so there's a lot of different definitions of remote patient monitoring, but trying to simplify it down to two kind of concepts. The first being it's the remote clinical management of these conditions outside of the times in which you're engaging in person with your physicians, specialists, nurses, coaches, etc. So that's one aspect of it. The second aspect of it is it's the enablement of the self-management or the lifestyle management of your disease condition itself. I think everybody's not defined by their condition. Ultimately, they're trying to put healthcare in the background, not the foreground. And so can you learn behaviors, habits, have the education, the coaching support to ultimately improve your health long-term? So that's how I would characterize kind of the remote patient monitoring. How this actually happens is the patient consents with their provider that they're going to be enrolled in this program. A tailored set of devices are then provided. They're typically internet connected to tablets. Again, what you'll hear probably throughout is internet is a baseline for most of what happens here because you are remote and needing to be connected. But the individual patient, based on their set of conditions, they could be acute, they could be chronic. There's a variety of different ways to approach it. But they will get a tailored set of devices that are going to manage to their condition. So think if somebody has diabetes, it'd be a blood glucose meter, hypertension, a blood pressure cuff, and the like. Along with those devices, they will get some software application. It's either web or mobile enabled. The goal of these is to, depending on, again, the acuity and the severity of the illness, keep the individual on track. Part of their care plan to say, we need you to take your meds, your vitals at this part in the day. Here's some coaching and education material about your condition and some of the healthy habits you can take on. Maybe it's time for you to, journal, whatever it may be. There's also inclusive of the telehealth, so the video component of interacting. On the other side of this, there's the clinicians. And so we all know, and we've heard so much about burnout clinicians, right? Especially through the pandemic. And certainly we have a real issue around aging clinicians where we're not getting as much filled through the nursing, the physician ranks coming up. And so there's a huge access to care issue. So it's important, as Kai was mentioning, and just thinking about how all of this works, but on the clinician side, they're able to view this data. And typically what they're doing is looking at indications of the progression of the disease being in the wrong direction and by interacting with these individuals as these are occurring. And so when you bring that together with the lack of access to care, what we've seen over the last 3 years, where hospital beds are being filled up consistently, clinicians are being burnt out, retiring in droves, patients are left months at a time of not having access to a clinician. These types of programs, when deployed correctly, really alleviate that access to care point. They keep patients healthy and out of the hospital. Clinicians feel more engaged and intimate with the patients rather than these 15-minute interactions inside of an office. So that's how I would kind of define remote patient monitoring. I think I'd give you 2 examples of how this works today at different ends of the spectrum. And so as we got really into the heart of the pandemic, hospitals were really, and they still are today, facing huge capacity issues. Meaning that I can't you come into my ED or wherever the entry point is, and I can't provide you a bed to take adequate care of you. And so oftentimes patients are getting put into observation wings, they're creating offsite centers, they're deferring. It's just been a big challenge. And so CMS came out with an acute hospital at home program that allowed essentially patients to receive an acute level of care as if they were an inpatient in their home. And so as a prerequisite of being a part of that program, hospitals, I believe there's now over 250 health systems that have done this at least for a year, and more are coming. The prerequisite is that you have to provide the same level of services in the home as you would on the inpatient floor. And that includes sending a nurse to the home twice a day. That's, you know, the meals, DME, labs, infusions, everything that you would come to expect in an inpatient setting at home. And these programs have been enormously successful for every single healthcare stakeholder because, again, it keeps the patients out of the facilities, so they're at home. These clinicians, and I have so many anecdotes of nurses that were getting ready to retire, they get enrolled in these programs. And these nurses are a little bit different than the traditional home care environment. These are acute care nurses that have spent their careers in ICU, ED, inpatient care that are coming into the home, and they've got they've been revived completely, and being able to spend an hour at a time with the patient, their caregivers, their personal care assistants, seeing the home, interacting, identifying some impediments to where they could be getting better. And one example of that has been, there was an individual who was really struggling. The nurse got in there and saw that he had not washed his clothes for over 6 months. And upon digging in, they found out that the laundromat where he gets his clothes washed changed from taking quarters to you had to have a debit card or credit card. And so when we start talking about social determinants, they were able to help him get enrolled and really start getting, and they went it back and had all his clothes clean. But those are the types of things that really start impacting and adding up over time. So that's one example. The second one is more of the chronic disease management side, as Brooke was mentioning. This is a little bit lighter touch in that you're not having to send people into the home, but you're really managing to the different vitals and ailments within certain conditions in which you can get ahead of, and then sparingly as needed, you can interact with your clinicians, your primary caregivers, as in between visits as things arise. But the ultimate goal is to be able to have you be able to self-manage, your caregivers engaged to self-manage those disease conditions. So that's kind of what I do in remote patient monitoring. I'm really excited for it. I think we're in the infancy stage of what will actually happen with all of these technologies. But go ahead.
That's phenomenal. No, thank you. So it sounds like you're kind of laying the groundwork for patient-centered medical home and things of that nature. And when you hear about that, so you and I approach this from a health policy standpoint. I think when people initially hear about this kind of thing, they must think, oh my God, that sounds like it would cost a fortune. How could we ever support something like that? Could you talk a little bit about what the cost is associated with that and how that might overall implicate in one direction or another overall healthcare costs?
Yeah, so there's kind of two parts to this. One is in that example I described, the acute hospital at home, and there's a variety of different offshoot type of programs, and you can think about oncology at home. Really, it's the high acuity of care into the home. There are pretty significant startup costs when you think about creating a brand new infrastructure to treat the home as a new venue of care. Think of it like a brand new hospital. This is a virtual setting in which you have to deploy clinical resources, ancillary services into the home and have that high level of care. So there is a learning curve and a high cost to get started. But what's been overwhelmingly clear once deployed in these programs, and most organizations around the country today are running anywhere between 5 to 10 average daily census within these programs. There are some much bigger that are running 40, 50, but we're not really seeing the magnitude of scale yet. But those that are actually running it have seen just complete change in the patients and their way to interact. They're not obviously coming back within those 30 days of being discharged from the hospital, which is a huge savings. They're opening up beds within the hospital space for those that truly need that high touch care that can only be delivered into these facilities, and really pushing out those that have some sort of predictable end to this episode. And so the cost savings element to that has been pretty significant, which interests certainly CMS and other health insurers that are, and employers that are covering the cost of this. There is, again, and this could be its own workshop, but the reimbursement for these through the pandemic, through the Emergency Act, it was at parity of, so you were getting paid the same amount as a health system if the patient was sitting at home or if they were in an inpatient hospital bed. Some commercial insurers have continued that. Most have started to move off of that parity. And there's still an outstanding question. Ultimately, it will cost less to deliver those services into the home as it does into the hospital. How much and what is that kind of balance so that it makes it worthwhile for the clinicians to be able to go deliver that care? That is a huge outstanding question that is yet to be determined.
Fantastic. I think that speaks to a really important point, that the entire delivery of care is shifting, right? So the hospital being the centerpiece of the healthcare system is changing, right? That we're experiencing a greater delivery of care in the community, in the home, saving the hospital for those cases that you're talking about, right? The biggest emergencies, right? Those who need that level of intense care that could never be delivered in the home. And that's, I think, fairly useful for people with disabilities who often are managing chronic care conditions. So I have a lot of personal experience with remote patient monitoring systems during the pandemic. Right before the pandemic, actually, I came down with sepsis. So as the pandemic started, I was in a really fragile state and needed to be monitored, knowing that the hospital was not a safe place for somebody like me who is significantly immunocompromised to be. And I think that this was the case for a lot of people during the pandemic. It was a really frightening time for others who are immunocompromised, have secondary healthcare conditions. So John and Kai, before we move to another aspect of the conversation, can you talk a little bit about what circumstances present the best or the most significant opportunities for these kinds of technologies to be used, and where do you see the future headed?
I don't know if the audience wants me to continue talking or let give Kai a chance and I can follow on.
Go ahead, John.
Okay. Yeah. So just to build off a few of those thoughts, one, in a particular example you described, Brooke, where you're there and you're in a vulnerable state, the industry, as I mentioned, has made huge headway into being able to deliver care into the home, in particular for the higher acuity conditions. And I know of many different health system programs deploying programs to manage patients with sepsis in the home. And there's a variety of other different types of programs, but one in particular that many health systems are taking on is these early discharge programs. So once you do make it to the hospital and you are in an unfortunate situation where you are immunocompromised and there's huge risk of being there, many health systems have started early discharge programs where they, rather than have a course of stay of 3 to 5, 9, 6, 9 days, they cut that off, get you home, have continuous monitoring and all the capabilities around that, including a clinical service into the home, to manage you there to the completion and the satisfaction of the care teams to make sure that you're happy, healthy at home and out of the hospital. And so I think there's huge promise there with those. It certainly opens up the capacity, again, as we mentioned, for those that need to be there, but it also gives those patients like yourself who really concerned about the whole episode of care, if you can get home to do that. The other aspect is just health insurers, payers have really taken an interest in this across their members and the individuals that they serve, and they're partnering across the country with health systems around this home and community-based care concept and creating, as you mentioned, the personalized medical home type model, where again, it could be oncology, it could be on a specific disease condition, where the ultimate goal is to identify your past utilization of healthcare services and predict, if we were to put a model like proactively taking care of you in the home, giving you everything that you would need to be happy, healthy, out of the hospital, what will that do downstream for us? And I think the conclusion 100% for all of the payers is this is what we have to do. And I think now the health systems, seeing the pandemic and still continuing down the value-based care journey, are all on board as well. And so these programs are happening now, and it's really exciting to see the results coming.
That's great. Kai, you want to jump in?
Yeah, no, thank you, Brooke. And John, that's really exciting and very great to hear of all of the programs happening and also that it's expanding. And Brooke, to your point earlier and your experience with sepsis during the pandemic, it is so important to have that option to not have to leave your home, to continue to have that reassurance and the oversight from the providers in the healthcare industry to be able to let you know when things are okay and to escalate and help out when they're not. I would relate this to a very less severe experience, but another example of how telehealth gives opportunities for people who might be immunocompromised, much less severe than the sepsis. But my mom has discoid lupus, and when the pandemic hit, from the stress of the pandemic, most likely, her discoid lupus had a flare, and she ended up having lesions on her face and her hands, and they became so itchy and painful. And while it might not have been threatening to her life in that moment, going into the office for a doctor's visit might have ended up making her flare worse or exposing her to other illnesses or to COVID. And that made her feel very nervous and desperate to find the care in a way that she didn't have to go in and expose herself to those external factors. So it's not only the external factors, but also personal situations that can impact this. And my mom, she was so desperate for medication to get relief from these lesions on her body. And so when she was able to finally get the telehealth visit with her rheumatologist to get the prescription that she needed to get that under control, it just was the best option for her and gave her just immediate relief in terms of having the ability to connect with somebody who can actually see her, because otherwise she was getting so frustrated and scared that she couldn't get the specialized care that she needs from a rheumatologist. So in this case, telemedicine offers such an opportunity for people who might be immunocompromised.
That's great. I mean, nobody wants to be a patient, right? Nobody wants to be in the hospital. Nobody wants to have to ascribe their identity to being a patient, right? And for many people with disabilities, right, their lives have been looked at from this medical model of disability, understanding them to be the weak or the unwell, the sick. And I think the programs and the interventions that you were just talking about help to shift that, right? Everybody would prefer to be at home, taking care of their medical needs in the most comfortable environment they can, outside of the hospital, which creates all sorts of complications. You're not only from an infection standpoint, but it's disorienting, it's lonely, it's frightening. It takes up, as John mentioned, bed space that could be used for other people. So to have the center of care at the home where people feel most comfortable and feel most like they're a part of the community and less like a patient, I think is really critically important. So thank you for sharing that, guys. But we all know that health and wellness involve more than just interactions with healthcare providers, right? That's just something that we all understand, and that health and wellness really is a way of life built on many different factors in our environment. And you kind of referenced the social determinants of health that I was talking about before. So, Brianna, could you talk a little bit about social determinants of health and how wheelchair users in particular might experience challenges in these areas?
Yeah, absolutely. Thank you, Brooke. And thank you, John and Kaya. I'm over here trying not to be distracting, but it's really hard to sit still because I'm so excited by this conversation and just so excited to hear both of you talk about the way that care approaches that you work with have changed during COVID, especially because I haven't worked in that world for a little while. And for a long time, I had been working and kind of trying to figure out these payment methodologies for value-based payment and trying to evolve the conversation around social determinants of health, which, as you said, Brooke, is maybe framing that people have gotten used to in the past few years. And it's, but if we haven't, if people listening haven't experienced that term, it's really like a great new paradigm to describe things that we've talked about in the disability community for a long time. Like hearing John talk about like the home is the site of care. Like for those of us with disabilities, like we know how important our homes are because we're used to the world not being arranged for us. And so many of us have this experience of our homes not really being accessible and caretaking of us. And then hopefully many of us have the experience of the opposite, where our home is like this cherished place where we can fully access everything about ourselves that we love and really like live into the fullness of ourselves that we don't get to when we're patients. And I think that like really to have this framing of SDH, as I'll say, social determinants of health, really brings together things that we've fought for in the disability community for decades, right? But I think has often been in silos. We think of, housing, right to healthcare, right to access physical environments, transportation, right to work, education, socialization, all of these things brought together. And what that's motivated is research into the pervasiveness of SDH and how it goes into our well-being overall. And it used to be certainly, and I hope this conversation has changed, but so many funders would get really defensive by the statistic that about 90% of what keeps us healthy can be attributed to social determinants of health. So 90% of each dollar that gets spent in healthcare didn't start when you got to the emergency room. It didn't start with that acute episode. It started with an issue that could have been mitigated, could have been dealt with if we paid for the social determinants of health before we got sick. And so we think of these things, first of all, work and education absolutely are huge ones that payers have been looking to for years, especially because we can think of them as things that recoup costs. But ultimately, we're really talking about community integration, and we're talking about socialization. We're talking about the things that help us live in the community and live well in the community and afford us the opportunity to really take care of ourselves. And so when I think about all these things coming together, where we're talking about, the medical model kind of embracing this new methodology with the social determinants of health, we're talking about the social model of disability. We're also talking about really a rights-based framework in the Olmstead Act. Our right to full community integration is really embedded at this place. So the ability to independently access inclusive community life, right? It's fully challenging for all people with disabilities. Yet, of course, for people who use wheelchairs, they have unique structural challenges. So I intermittently use mobility aids. I'm not a wheelchair user myself, but I can speak to, I think a little bit because I think about the structural environment a lot as a person with a background in urban planning, and I work in transportation systems now. So our ability to afford and access appropriate and updated mobility aids, including wheelchairs, right? The ability to receive the desired level of support, not the one that you're given or the one that you're forced to receive. The ability to live in housing of preference, in a place of preference, next to the neighbors that you want, next to the family and friends that you want. The ability to easily access rollable environments and not just immediately outside of our home or in a path that we know that we can navigate safely, but in the same way that our neighbors and our friends can. The access to wheelchair accessible public transport and the right to be content with wheelchair accessible vehicle supply that we've never experienced in the US. We have never experienced a supply chain coordination of wheelchair accessible vehicles. It is an entirely unfunded aspect of our rights to live in the community. And we also know that for people who use wheelchairs and other mobility aids, we're more likely to experience other health challenges, right? Including immune, cardiovascular, digestive, emotional well-being, the ability to manage our mental health, and also the socioeconomic relief where we can make the time and energy for socialization, proper diet. All of these things are more difficult when we're just focused on navigating structural ableism, when we can't navigate our environment. And of course, we know, we've always known these things are not incidental to mobility disability. These are fundamental aspects of structural ableism in our environment. And, John was talking about home as the site of care. So as I was talking about these layers of paying for SDH, but really this social model of disability and right to community integration, we've had data on this for so long, and not just relative to disability, but as John was talking about and Kai was talking about, telehealth, like the ability to have a smartphone and internet access, the ability to pay for laundry. I've seen studies about paying for mattresses, paying for sheets for people to increase, ability to sleep and sleep well so that you can manage the rest of your life, manage your healthcare. There was research in New York City a decade ago demonstrating that just buying an air conditioner for somebody who lived in the city cut hospital utilization for people with COPD, for people with asthma and cardiovascular distress, to the point where it would no longer put those hospitals in the red and have experience of overcrowding in those hot summer months. And yet still, there is not a payment methodology for paying for an air conditioner as a healthcare device, despite the fact that it would save $1,000 a day or more in urgent utilization costs. So I love the conversation about all of the ways that these are layered together, and to think through the specific challenges of home as a site of care, and then broaden that out, everything that brings us in between home and our points of socialization, and then include our medical system as a part of that, to really think about, what if we could dream full community life? And what if we could advocate to have it paid for, feeling fully confident that it was 90% of what kept us well? Thank you.
No, thank you, Brianna. That was just like so rich in meaning and in content. Thank you for that. So you referenced the Olmstead Act, right? We could talk about the Olmstead Act or the Disability Integration Act. Like these are, they're kind of contextualized or siloed as being disability policy, but they're really like they're civil rights legislation, right? We're talking about the ability to achieve basic rights in the community. Why do you think it's been so difficult to mobilize interest and involvement in these kinds of issues when they are just so fundamental to how the United States approaches humanity?
Oh, wow. Oh, no. We'll have to write a whole treatise on that.
All right, fair enough.
I have thought about that for a long time, especially because, well, so much of my advocacy has been in the psychiatric survivor community, and of course the leader in our community, whom we lost just last year, who inspired the Olmstead Act, was a psychiatric survivor, and the legislation was, of course, inspired by her fight to be released from a psychiatric institution where she was forced to live and had no reason to live there. I do think that because of its origins in institutionalization, and because we're so stuck in this framework of what institutionalization means, we think of it in terms of very limited scope. I think about, if my environment is inaccessible, if my workplace is so inaccessible that it drains me to the point where I cannot leave my home because I have not been afforded the supports that I need in my environment to live comfortably outside of my home is now an institution. I worked in housing justice for a long time doing advocacy work. I talk about homelessness as an institution. Homelessness as an institution. The social barriers that prevent people from full housing. Living on the street is institutionalization. And I think that when we think of that as really the ability, like, what if the world allowed my movement in this direction, any direction, to open my door, to feel like I could, experience the fullness of my mental health, my social health, my intellectual, my economic, my spiritual health. If we thought of every door that we feel closed all day, every day, that we know as people with disabilities, but that every single person, to your point, it does experience because of structural limitations. If we thought of every closed door as a trap, as something that kept us institutionalized, and realized that if we had a mechanism to push it open, we could experience more freedom, I think that could dramatically change the conversation. Now, I obviously switched to a very conceptual idea and a very ideological idea, but I think it can get very practical when we think of what explicitly are those limitations to our community well-being every day.
That's fantastic. Every time I talk to you, it's always such a rich and incredible conversation. This is nothing short of that. So thank you, Brianna. Yeah, it's great to have the depth of this conversation. I think is just incredible. And we almost take these limitations as given, right? We've created a world in which these limitations or these barriers to inclusion are just taken as a matter of fact, rather than having these conversations about how we can and should and really must address them. So we have things like equity, not just healthcare equity, but equity of all kinds. So, historically speaking, the development of our technology, just like the development of our cities and development of all different kinds, has been without really a full appreciation or attention paid to the lives of people with disabilities and their needs. So what do you think some of the consequences of this have been?
Is this question also for me?
For you or anybody else who wants to jump in.
Yeah. I haven't been able to shut up, so I'll pass it to my colleagues if they want to jump
I can speak.
Oh, go for it, Kai.
I'll speak from the technology side, and Brianna, that was amazing. I really like your points and how you really drive the important factor of it being so many layers, and there's so much going into this. It can't just be solved by one thing. We can't just address one thing. And it's not just as easy as fixing an accessibility issue on a website and then now everybody has access. It's so many layers to accessibility. It's how do people, get air conditioners? How do people have the money to be able to buy the tools that they need to be healthy and to have the access to care that is needed and to live healthy and happy lives? And to the question about what are some consequences of not thinking of the disability community first when we first design things, the consequences are huge and they're everlasting. They're things that we'll have to continuously address and find creative ways to prevent those from happening in the future, and also to mitigating and fixing the issues that have happened or the consequences. On the technology side of it, I would say some of the consequences are that websites and mobile apps just plain don't work with assistive technologies. There are a lot of barriers when you're trying to use an assistive technology that is paired with a computer. For example, say you're using a screen reader on a website. If that website is not coded correctly to be announcing form input fields correctly, they might just be announced with no context at all. And so then how does somebody fill out the form and register to get care? That's one huge example of a consequence of it. And the consequences for the company of that is expensive remediation, a lot of it driven by a rise in web accessibility lawsuits. A lot of companies are getting big lawsuits. I think there was like 2,000 or something along those lines of lawsuits last year in the US. And also big companies now, and even small companies, all companies are needing to rely on the disability community, and especially building up accessibility teams and that expertise in-house. And it is just not great that we have not had that from the start, because now we're having to work backwards and it's so expensive. It's not time effective at all. And it has true consequences on those who are impacted by inaccessible websites and mobile apps.
That's fantastic. And I think that the barriers that impede end user adoption for technology for people with disabilities are certainly multifaceted, right? To the points that you were just raising, Kai, in addition to economic factors, knowledge, knowledge limitations, a lack of community supports or peer supports to help that level of adoption. I think that these are all things that are really important to think about and to integrate into our thought processes when it comes to innovation, right? How do we make sure that as we approach accessibility, we're talking about accessibility in all its different forms? So I think that that's a really important point. Kai, thank you. So you basically—
And Brooke, I might just
go for it.
Oh, sorry.
Yeah.
Sorry, Brooke. I was just going to add one thing. You know, as you talked about growth, so clearly we saw through the pandemic the silver lining of this is it accelerated a lot of these initiatives that we knew were important, but just never got the time of day and prioritization, specifically as it relates to telehealth and some of these other concepts that we're talking about here. One of the drawbacks has been is it's moved so fast that we've missed a lot of just basic design, you know, and understanding all the stakeholders. And it's a very narrow issue, but I want, you know, just point it out as I think it's relevant is when we talk about like hospital at home, it's considered an inpatient stay. Therefore, a personal care assistant is not reimbursed the way they normally would be. And so when you start thinking about things like that, again, being a novice in that space, I know there's probably a million other things that are being missed. At the end of the day, I guess my main theme is we've got to consider all stakeholders, including the caregivers, the personal care assistants, the sandwich generation, those that are also taking part in this, and make it easy and efficient for them to take part in this. Because if we lose sight of them as well, it's going to be very, very hard to make these models successful.
Right, right. And that's not necessarily the fault of the innovators, right? I think very often it's the case of a lack of knowledge, right? It's not a deliberate malice, or we're going to be exclusive in how we approach technology. It's a lack of fully understanding what people's needs are, or how multifaceted an issue this all is, right? We're not just talking about one clear medical issue. We're talking about many other factors that go into how technology is approached, how technology is integrated into healthcare, and then ultimately how people are able to achieve or not achieve healthcare equity. So I think that's a really important point. Yeah, so given what we've been touching on, so we touched on many things in the course of this, almost an hour, but we're painting, I think, a really strong picture, a really clear picture for a social understanding of disability rights, even though it's a conversation about healthcare and about medicine or medical interventions. We're moving away from the medical model of disability, which envisions disability as a medical issue, and really that alone, or some kind of medical failure, and one towards a social model of disability that puts disability in a context that includes things like access to employment, access to education, the kinds of technologies that we innovate, the kinds of policies that we enact, the environment that we build. All of these things either enable or further disable an individual. So I'd like you all to just talk a little bit about that idea and how you think it's relevant to some of the work that you do. And anybody could jump in to start.
Maybe just develop a little bit more when I got really dreamy and conceptual about some of my ideas about our rights here for social well-being, because I think in terms of specifically about the social model of disability, about some of those framings that I mentioned of like, I think about, SAMHSA's kind of 8 dimensions of wellness. I think of my economic health, my intellectual health, my, spiritual health, environmental, physical, my social well-being, all of these kind of places of well-being. And then I think of disability and what we mean when we say accessibility. And I talk about accessibility as being 3 things, and it's a million things, but I think talk about it as 3 different things. I think of it as independence, safety, and self-efficacy. So I think that our well-being is tied to the right to live as independently as we want, safety and perception of safety, and self-efficacy, or the right to know that when I interact with my environment, I'm going to get the same results. Or I can trust myself, I can trust my environment and myself that what I put in is going to yield the same results back to me. It's that self-confidence. And that's an objective reality, and it is also a subjective reality, right? It is what actually happens to us in those 3 dimensions. That is accessibility. But accessibility is also our subjective belief in those 3 things. And so I really think across all of these dimensions that the social model of disability, we think so paternalistically about oftentimes in our healthcare environment, because we're not used to a model that essentializes our contentment in those areas, our happiness, our joy in those areas. And so I really think about, like, what if we could, as I mentioned, like really imagine what joy and choice would look like. And this might sound really conceptual, but I think it gets to very specific things, as John was just talking about with the needs to integrate caregivers and then have a payment methodology that kind of matches our understanding of home care, but then also our right to choose who is in our home, to deliver support. That has a lot to do with our perception of independence, and therefore our ability to choose joy in all of those other areas of our life and to move towards well-being in all those areas of our life. And so if we're afforded, 7 hours of a home care attendant Monday through Friday, but actually we need 3 Monday through Wednesday and 12 Thursday through Saturday, like the right to choose is like an explicit way to operationalize accessibility in a healthcare methodology. And that, I think, could really close the gap between what we think about in terms of accessibility in the disability space and well-being in the medical model and in healthcare payment schemes.
That's great. I think that's a challenge that many people who live with spinal cord injury, especially those with quadriplegia, who often rely on others for assistance. It's a conundrum that they're facing, right? The desire to live independently and outside of the hospital setting, and the need to have supports in order to do that, where those 2 things don't always go hand in hand because of a lack of policy decisions to bolster the healthcare force and to make sure that people's needs are attended to in the right way, though with the choice that you just mentioned, Brianna, right? So you have services provided at the right time, not just anytime that accommodates somebody else's schedule. Like these are lessons that people learn over time. It's a battle that I am experiencing myself and many others experience, and these, I think, are frustrations and areas of concern that people try to navigate as they move and as they transition from a rehab setting to a home care setting, right? There are gaps that need to be filled, understandings about how life is going to be lived that only come with years of experience. So I think this is a good segue into Randy. I want to make sure you get into the conversation before we take a break. You've been sitting so patiently there, in front of that mountainous stack of books with your wealth of knowledge. I want to make sure that you are fully integrated into the conversation. So you do work in the rehab setting, and that gap, that divide from the rehab setting to home can be a very tricky one to navigate. And you are doing work to help smooth that transition, particularly from a technological intervention standpoint, and trying to address some of the challenges that people with spinal cord injury experience. Can you talk a little bit about this and some of the work that you're doing and some of the challenges that you've experienced when it comes to making that transition?
Sure, Brooke. Thanks for touching on this, what I think to be a really challenging part of this roadmap to the time that individuals are dealt a very life-changing catastrophic event, leaving them in a state that in many cases is like nothing else they've ever experienced. And it turns from 1 minute being able to do things completely on their own to the next minute relying on so many other people to help them do simple tasks that many people take for granted. You know, I've been sitting here and digesting so many great pieces of information from John, Kai, and you know, the details that Brianna brought up about social justice. These are great opportunities and providing lots of great resources and potential choices that individuals with tetraplegia have to make. And when I was sitting listening to all these opportunities, I felt a bit of a challenge, mental challenge, between being excited but then also thinking that I'm drinking through a fire hose, and I am trying to quell my overwhelming sense of concern about all this information that has to be relayed to an individual that just had an injury, and they need to understand, remember, apply it, and make choices without having any decision fatigue, and understanding that their life is going to be flipped, and they need to do this in a very short period of time because they're going to be discharged from the rehab hospital and they're going to go home. And people are going to tell them, do you want to do this? Do you want to do that? And so from my experiences at Spalding Rehab Hospital, it's a fantastic environment, lots of resources. Individuals that come there have the privilege of being able to access these resources. The issue that I see is that a lot of these resources come to an end, and the reality hits them when they are discharged to their home environment, and those resources are no longer available. Their access to certain tools and technologies are no longer available. Or, they worked in this environment, but they won't work in another environment. And many of the tools that they were afforded with during their care become much more difficult to navigate how to get those in their own home when they're searching and talking with Dr. Google about some of the tools and resources that they have available. It is the wild, wild west. And they are drinking through a fire hose, just like the clinicians that are trying to advise them, their caregivers who are also trying to keep up with technologies that have a lifespan of 2 years. And it's a very challenging time for these individuals. So when I see challenges like this, I want to come up with a solution. And so part of my role at Spalding is to help improve the integration of these resources for individuals, not only in the Spalding network, but also individuals that are not part of the network, but can benefit from these resources through other forms of education and training. But for those that do get care through Spalding, we are providing what we hope to be immediate low-cost impact of tools that they will have readily accessible at bedside. For instance, we are allowing and providing opportunities for patients to and their caregivers and loved ones to 3D print very low-cost, simple solutions to improving autonomy. And we can do that in-house. And if we want to scale, we can partner with so many other companies and industry that are already in a place that they can scale up and provide these resources in the masses. But for individuals to have access to these types of tools in-house without costing any money is one way to introduce them to the tools that they need to think about when they go home. We're creating smart rooms and simulating smart homes in the hospitals so that they understand the significance of the Internet of Things, which are in the order of billions and billions of access points across the globe, and that's not going to change. So the more time they have to learn about these tools in the hospital setting with clinicians who are also involved in the learning process and the co-development of some of these tools, the better. As Brianna pointed out, it is about the person, and so much, and I believe Kai and John touched on this as well, so much of the technologies that have developed over time have been highly engineering centric, and we see the opportunity of having individuals involved in these types of technologies while they are in a process of rehabilitation is an opportunity for them to be co-developers of what works, what doesn't work, as opposed to let's throw spaghetti at the wall to see what sticks. So that is kind of, I want to keep it somewhat brief because I'm assuming that people will need to take a break at some point, but there's a driving point for me in my work at Spalding, not only as an engineer and as a clinician, but also as a caregiver. These are things that I think the general community often neglect, partly because they're blind to some of these challenges until they have an immediate loved one or they themselves have gone through the challenges of paralysis. And then the overwhelming choices that people have to make can, pardon the pun, leave people paralyzed with what types of choices are going to be the best for them. And in some cases, they're listening and they're vulnerable to the information they receive. And the way it's packaged can be far more attractive than the actual product itself. So in some cases, individuals are not, and all of us are probably guilty to some extent, knowledgeable consumers of technology. We all fall victim to the mousetraps of different technologies that have the claims that they can do X, Y, and Z, and they can in a very precise environment. But when it comes to different environments, it falls short, and purchasing that $30 or $50 device or gadget just ends up in the closet, and the impact is very, very little. So.
See, when I said that I assembled a brilliant panel, I was not lying, as I'm sure you all can see, right? So Randy, you touched on some really, really important points, and that idea of what people are exposed to in the rehab setting and how that translates to what they are or not afforded access to in the home care setting is a really treacherous divide, right? When you're living, when you're trying to acclimate to a vastly different life pre and post injury, it's overwhelming, right? We're just talking about one facet of life right now. You have to learn to renegotiate or re-understand every aspect of how you approach life, right? It's completely overwhelming and to not have technology at your disposal, especially now as the world becomes, as technology becomes more and more integrated into our lives on a daily basis, right? To not have that level of exposure or that level of ongoing integration into your life can make you feel completely at a loss. I remember so vividly, I was in rehabilitation, this was way back in 1990. I was just a little tight, just 11 years old, and that was my first exposure to any kind of assistive technology, and it was a sip and puff activated switch that would allow me to insert individual letters into a computer using the Morse code alphabet, with puffs into a straw corresponding to dots and sips into the straw corresponding to dashes. And I remember using it for the first time, thinking, oh my God, how am I going to go on with my life? How am I going to continue being a part of the world if the only way that I can interface with a computer, even in way back then, and at that time, computers were not playing the role in our lives that they do today. If it would take me like 10 minutes to write one word, how am I going to do this, right? How am I going to continue to live my life? And things have changed, thankfully, right? We're living in an era where voice activation technology has been integrated not just into computer systems, but into our cell phones, into home assistants, right? And this becomes really valuable. And just as you mentioned, Randy, right, to have that level of engagement of people with disabilities right from the get-go, so we don't design things that are completely unusable, I think is critically important, right? Because it takes a lot of time, right? I don't want to denigrate in any way the level of forethought and innovation and concentration that went into devising that first piece of technology that I used, but it turned out to really not be useful at all, right? So that's something that I encourage all future engineers, existing engineers, to think about, right? So I know that in the audience today there are students from different research institutions, Rutgers and Harvard, and they'll be future engineers. So I encourage them to think along those lines, to think about how their technology needs to be guided and informed by lived experience before they start working on it. All right, so we will take a 5-minute break and then come back and talk about some additional points before taking questions from the audience. All right, so I was just saying, so we're trying to get a better understanding of technology use for people with disabilities, generally speaking, particularly for wheelchair users and particularly in the healthcare setting. But we'd like to know more about what are some of the impediments that people experience, especially as they transition from the rehab setting to the home care setting, or the home setting, not home care setting, the home setting, and where the impediments lie, whether they're financial in nature, knowledge-based, peer support-based. What prevents people from utilizing the technology that could change their lives or improve their lives? We have constructed a survey, and I believe there are QR codes on your tables. If you are able or willing to take the survey, it's about a 10-minute or so survey. It could be done whenever you're available. You could just scan the code. There's also, I think, some paper copies, so please, if you're able to do that, that would be great. Give us some more information about where we can direct our needs or direct our attention, right? Particularly with the Tech Access Initiative, it's better to was helpful to better understand where people's barriers lie and how we can work together to address them. So before we took our break, Randy, you had mentioned, right, that all of this content, all of the things that we have talked about, right, is like you're drinking through a fire hose, right, which I think is very much the case. I think that is what it's like to, or at least partially what it's like to go from living without paralysis or living without disability to living with one, right? It can easily be very overwhelming, but there's just so much that needs to be addressed, so many things that need to be done. We are investing a tremendous amount in technological innovation across the board, but a very small amount when it comes to the technology that's needed for people with disabilities, right? And the need is just so immense, right? The opportunity is so great and the impact is so tremendous that to develop that skill set and to make sure that future innovators and existing innovators are well informed when it comes to the needs of people with disabilities, I think is really of paramount importance. So when we think about the future of technology, particularly when it comes to healthcare for people with disabilities, where do you think the future actually lies? And what are some of the impediments that you might foresee in getting to that ultimate outcome? And this can be for anyone. And Randy, if you want to start, since you were kind of the bridge here.
I think where the greatest return on investment is for the healthcare system and the potential end users of technology is staying true to what it means to have personalized care. So meeting the technology to an end user or a person, not trying to overgeneralize these tools to create something that would be more or less a one-size-fits-all kind of model. I think we have so many technologies readily available, mainstream, accessible, but lack refinement to meet any one particular individual's needs. And it creates a lot of noise in the decision-making process for clinicians, caregivers, and individuals that would be using these tools. So I think the future is, in my humble opinion, is to avoid making things more complicated than what they need to be, and to focus more on addressing the individual's needs as the target for the technology. If there is going to be development of technologies, they need to be much more personalized, and I think they can be. I think the intelligence of these tools are going to be much more refined to be able to meet those needs. But the concern I have is that engineers and there's always this desire to create this provocative tool that oftentimes can be a little bit over-engineered. And in some cases, they're introducing artificial intelligence, but it's really, again, to the point where the technology is over-engineered by what I would call the Wizard of Oz, where there's still someone that's making the decisions about the intelligence of the device or the tool, and again falls short because it has constraints that have been built in and assumptions without the individual's needs put into that solution. So that's my long-winded answer to where I think things are going to be going.
That's great. That's great. Before we go on to somebody else, I think that's a really, really important point. So through the Tech Access Initiative here at United Spinal, we have what's called the Tech Access Group, right? So it is a group of wheelchair users who meet regularly on a monthly or thereabout basis to talk about their technological experiences, or talk about some of their frustrations. And in one of the calls that we had earlier this year, one of the members of the Tech Access Group talked about the fact that that night or the night before, he was transferring from his wheelchair to his bed, and he fell on the ground. And there was no way for him to figure out how to get from the position he was in to a safe spot. There was no technology that existed for this to happen safely. And that story really stuck with me. I think they ended up having to call the fire department or EMS in order to help him up into bed. This is a problem that I'm sure he is not alone in having experienced, right? And they're real problems for people, for wheelchair users. Technology to prevent the loss of a wheelchair in an airplane flight, or to protect it from being damaged, right? These are real concerns that wheelchair users have, and they're not necessarily front of mind when it comes to many people who are working regularly in innovation or in the engineering space. So I think you're exactly right, Randy, that we need to have greater communication and greater understanding of what people are actually experiencing before we start moving down the path.
And Brooke, we need to have more accountability. So there needs to be many more checks and balances, and it's really about when individuals that are using these tools, their input is so important. And I don't believe we are in a place right now where we're actually using their input in a way that's constructive into the next, how do we refine and create the next generation of these tools that can be used. And I think there's a gap from when somebody starts to adopt a technology, it falls victim to not being useful, it ends up in the closet, and that's it. That doesn't really inform something that could really be helpful to others, maybe not to that person, but it's still a potentially viable tool. It's just it has the wrong targets. And so that accountability and quality assurance needs to be embedded in these early adoption of technologies. And that information needs to be relayed back to the developers, co-developers, the clinicians, so that they can better understand how to, redirect these tools to, like I said, the more precise, personalized delivery of care.
I think that's a valuable point. People with disabilities are experts and nothing short of that in their own lived experiences, right? And I think that that's really valuable. Incorporating that level of expertise is really, is really valuable from the idea generation phase straight through to the marketing phase of technological development, right? There are insights that are born out of experience, born out of living with disability that forces creativity and problem solving in ways that many people don't necessarily always have to integrate into their lives that are actually quite valuable. And having that level of innovation and insight into the entire process, I think, behooves everybody. That's a
Absolutely.
great point, Randy.
It's huge. Absolutely huge.
So on that note, I'd like you all to talk a little bit about how you're incorporating the lived experiences of wheelchair users into the future of your work, and like, where are some of the opportunities? Where does the future lie that we can feel excited about and hopeful about when it comes to innovation?
I can speak about Spalding and the Travis Roy Center. That is a huge part of our mission, is to help improve employment and job opportunities for individuals that have lived experience that are underutilized in this space, which I think is a fertile ground for individuals providing help to others with more challenging conditions, and also those that haven't had injuries yet or disease diagnoses yet. So in the center, we are actively and have hired a number of really talented engineers, neuroscientists, physiologists, clinicians with lived experience in the center to help us identify how best to track these technologies from the time they're used in the hospital to the long-term use of these tools in the home. And as people age, as they change environments, their use of the tool may undoubtedly change. And so we want to have a good pulse on that. So in the center, we're actively incorporating as much as we can those with lived experiences.
That's great. I mean, we're living in an aging population, an aging world, as we increasingly come to understand some of the long-term consequences or consequences of living with long COVID. I think we're going to understand disability very differently, and the needs are going to, people with disabilities are going to apply to a much greater population, a much more substantial population. So the innovation that we do right now will invariably help a greater number of people, a greater percentage of the population as we move down the line. And as you know, as well as anybody, the level of unemployment among people with disabilities is quite high. So to use their experience in a way that's actually benefits everybody, I think is really is a fantastic innovation. So I applaud Spalding for doing that. Brianna, Kai, I know that I've spoken to you about some of the work that Uber and Teladoc are doing to incorporate the experiences of people with disabilities into your work. I'd love to hear a little bit about that.
Sure. Should I go first or?
Sure.
Great. Yeah, I was gonna say thank you to Brooke and Lewis and the Tech Access group, because being a part of the United Spinal Corporate Advisor Council for me and for Teladoc has been huge. I love joining the Tech Access calls, and a big part of my reasoning for why I join is just to listen and to learn from the community. Like you mentioned, Brooke, those with the disabilities are the ones who are the experts of their own experiences and of their own tools. I think nobody really is. I mean, I know I was hired as an expert at Teladoc, but hot take, I don't think that anyone is really an expert of accessibility or of disabilities. You're an expert of your own area, of your own experiences, and of your own needs and wants and preferences. So I'm always eager to learn, and I encourage everyone to continue sharing your experiences with everyone and make sure that your voice is heard. Your experiences are extremely valuable, and we are listening. And please share your experiences with detail as well. The more detail, the better.
Yeah, and I'll jump in, Brooke. I really haven't even talked about, my current job at Uber. I joined the team last June, and I'm sure that everybody listening has an opinion about the intersection between Uber and wheelchair mobility, right? Like whether you live in an area in a city where wheelchair does offer wave on our Uber does offer wave on our platform or does not. Of course, it's been in the news and litigation and all the things. When I stepped into the role last year, I in part even took the job because of this fantastic team called Product Equity and Fairness Work and these commitments around safety and racial equity that the company had met. And I just was continuously surprised, even in the interview process, to meet these like incredible people who were really had this vision and this ideological motivation. I was like, oh my gosh. And every day I still feel like I get to work with the best people in the world who, if they could, would offer full wheelchair access on rideshare tomorrow. And what I think that Uber, learned many years ago when it stepped into offering Wave on the platform was, of course, they couldn't run their model, which was to have individual vehicle owners operate waves or vehicle services. And that is because of the issues that all of us know as advocates, is because it's largely been an underfunded and uncoordinated supply chain issue, right? Like individuals can't always afford them because they're costly, and there are explicit supply chain reasons for why they're costly. We don't have the proper financial supports. We have uncoordinated fleets. We have like poor incentives for training and certification, poor safety standards and quality assurance at the state level. And so as we try to really understand our responsibility in the space, I think as an advocate, my perspective is always as an advocate and as like a policy wonk is like, these are not intractable issues. This is not magic. This is unlocking policy levers, and this has to be working together. So, when I think of like, there's no such thing as research or advocacy that works, for even a company as the size of Uber and the breadth of Uber, without working together to say these things have never worked. These things have never afforded me choice. I want full choice. I want to be able to reserve paratransit, take an ambulance when I need to, take public transportation when I can, call a rideshare at 11 o'clock at night when I'm out using my wheelchair and I'm drinking with my friends, and know that I can get a safe and dignified experience. And those are specific policy and supply chain investments towards increasing adoption across individual purchasing, training, certification, safety standards, lack of stigma of owning and operating a wheelchair accessible vehicle. And that's all advocacy work that we can do together. That future exists where we have full choice across mode of transportation.
That notion of choice, I think, is so critically important, and you referenced it before, right? I think that is an aspect of the conversation that many people with disabilities felt like they never had an opportunity to be a part of, right? That you basically, from a technological standpoint or an accessibility standpoint, it was basically what you were given. It was all that you could ever ask for. And even for that, you needed to be overly grateful for it or overly apologetic for any kind of modification that needed to be done. And I think we need to break out of that mindset, right? That people with disabilities have just as much worth and just as much value in the community and need to be treated as such. And if that comes down to having an array of choices so that they can live their lives freely and with as much participation as anybody else, then that's, just as you mentioned, a policy lever that we need to start trying to pull. And enough of accepting the status quo. Fortunately, I think we're moving into an age where the status quo is no longer viewed as acceptable, and people are willing to fight to change that. So thank you for the work that you do to make that possible. So let's wrap up the conversation a little bit by talking about the relationship between technology users and technology developers. So this, as we just mentioned, this line of communication is so critically important so that we're innovating in the best way possible. But what are some of the barriers or challenges that innovators or corporations might face in building that line of communication, or just an accessibility agenda in general, do you think? And anybody who wants to jump in, go right ahead.
Yeah, sure. I can take a shot at that. I spent a lot of time thinking about some of the macro challenges, specifically as it relates to supply and demand. The demand for healthcare services is exponentially increasing. The supply of being able to provide those clinical services is exponentially decreasing. And so there's a huge opportunity for technology. So what Randy had mentioned around personalized care, understanding the individual at the individual level of what constitutes something that is alarming for this individual compared to somebody else, and make sure that they're getting appropriate prioritization and care from those clinicians that are available. So when we think about the challenges, it's how do you marry together? There are endless amounts of digital health companies. I mean, there's one that starts up every single day, and it solves a unique problem. The challenge is the healthcare system is so large and complex with so many different stakeholders and so many different incentives. There's an infrastructure that it needs to integrate into, and you have to really understand that infrastructure and how to integrate it in as you're solving these specific problems, or else you're just creating more noise, more challenges, more layers that you need to kind of dig through to make it successful. So, I would just, the other aspect of that too is just there needs to be some level of financial innovation within healthcare. The relationship between the individual and their clinician, their health insurance carrier, whomever it may be, seems to be very episodic. I see you now, and that's it. There's got to be a way to which you can connect those individuals long term so that you can make the investments in their health. You can bring things into their home. You can do things with technology that allows you to be healthy over time and not just battle this episodic arrangement. So again, I think the innovation on the technology side is great, and there's a lot of companies that are solving a lot of great things. If you don't have that entire picture of the healthcare ecosystem and how this works, it just becomes another thing that either the clinician has to work with to figure out. If you think about them and in the backdrop, it's that just inverse relationship of supply and demand. We've got to get very good at understanding what's happening with the individual at their personalized level and be able to prioritize them in front of the line as needed, and then give them that ongoing education, support, nudging to keep them successful.
Yeah, I think that's a phenomenal point, right? And often, so the healthcare system, as we all know, is extremely complex. Often we're talking about access to scarce resources. It is people with disabilities who are thought of as the less worthy, right? When it comes down to the triaging of care. We saw this during the pandemic. People with disabilities have real fears about how their lives and their needs will be valued vis-a-vis people who don't live with disability, or at least not demonstrably so. And like that, I think touches on the heart of the issue, is making sure that people know that the lives of people with disabilities are worth it, right? Are as valuable as anybody else's. And to think about care at the level of the individual, right? Like that is revolutionary thinking. And think about how liberating that is, especially for a population who utilize a greater amount of healthcare than the general population. To think about the level of freedom and reduction of fear that comes into play when we know that people are caring for us and understand our needs at the individual level. And I think that all of that it's difficult but achievable, right? All of this work is difficult but achievable. Just as Brianna mentioned, right? We're not talking about magic. We're not talking about something that needs to be created out of the thin air. We're talking about things that are actually achievable if we prioritize things appropriately. All right.
Couldn't agree more. And I think about your example of somebody falling out of their chair on their way to bed. And there are technologies today, and there are scenarios where there's automated technologies that individual falls, they can hit a button or it automatically detects the falls, which triggers an alert to their specific care team that deploys on the ground resources to the home to make sure they're okay, without them having to do anything. Not saying it's the greatest solution today, but when you start thinking about all the things you can do with technology, the key ingredient is how do you introduce it to the care teams, the clinicians, the caregivers, whomever it may be, so that they can act on it. I think that's a big challenge.
Absolutely. And making sure that clinicians know about that this technology exists, right? And how to get it to people in a way that makes sense for their needs and their lives. Randy, we get it.
I think one hidden but very, very important roadblock that I'm seeing at the Mass General Brigham, and I know it's a very sensitive issue between industry and healthcare, and that is providing these resources, but not undermining PHI. So as you're, and this is
personal healthcare,
state to state differences. And so you have, important health related information that's specific to an individual, that if you're opening up opportunities to connect with these individuals in their homes, is there an added increase in vulnerability that they may be hacked by ransomware when they learn about this vulnerable individual and their family that has some disease or challenge, and this can be used against them, even though we had all the intent to provide them with the resources so that they can operate things in their home without using their hands. It seems voice is a very powerful thing, but implementing voice even in the hospital setting implies that you're listening to anyone that walks past that room, and that implies vulnerable information that we can't close out. And so even though individuals bring in their cell phones and they're using Siri or Alexa, that's theirs, it's not the institution. And so there's these roadblocks are quite challenging to break through. And so right now, I think that's one of the hidden challenges with, in my opinion, that some of the institutions are really having a struggle with how to give this autonomy for people with existing technology that works, but without undermining the level of security that they need to protect their identity.
And that's a real challenge, right? When it comes to protecting health information, how to maintain people's privacy, right? Those are real concerns.
But we spent 2 years talking about this with Amazon. 2 years, and it went nowhere.
Sure. So I do a lot of work in medical ethics, as you all know, and what has regrettably been the case is that medical ethics lags behind innovation, right? So we're constantly trying to correct for innovation that's already down the pike, right? we are less anticipatory of challenge and more reactive to challenge. And I think that that's a problem, right? So these are questions that I think ethicists and thinkers need to be addressing right now, so that as innovation moves forward, we're actually doing it in a way that's inclusive. But you're absolutely right, that we need to be thinking about all sides of this to make sure that the innovation that we ultimately bring to fruition and to market is not going to put people in a worse situation than before. All right, so I know we have just a few minutes left. I want to make sure that we hear from those in the audience, from the clinicians and everybody who have been a part of this panel. So Matt and Lewis, I will turn things over to you to man things on the floor.
Okay, thanks, Brooke. So,
Raise your hand and wait for Lindsay.
It's a little hard to hear you, so I don't know if you need to come a little closer to the microphone. I don't know if others on the call are having the same problem.
yeah, I can repeat the question, Brooke, if you're having
Okay,
trouble
great.
hearing them.
Excellent.
Hi, everybody. My name is Susan Bergman. I'm a retired physiatrist, and I used to work at the New England Regional Spinal Cord Injury Center at Boston Medical Center. And there are some disconnects that have been brought up in this discussion that I think need to be focused on. Number one, tech is wonderful, but it's a tool. And one of the issues that has made things worse for people now than they were even in the 1980s is the erosion of the human relationships, the doctor-patient relationship, the team relationship, and the idea that technology can substitute for this. It can't. It's like expecting a hammer to build a house. The second thing is the unit I used to work on was a cross between a hospital, a college, and a boot camp. It takes a long time for people to learn what they need to do to take care of themselves and maintain good health. There's not enough time with the short lengths of stay that we have now for people to either hear that information or even to absorb it, because they're trying to deal with acute medical issues. So I think we need to figure out how we can supplement. The third thing is that clinicians are being diverted from patient care to data management and even data entry, which is a stupid way to utilize people with high levels of training. The team approach is all but gone. So I think it's not as simple as it would seem. Part of the issue is that the insurers have equated low cost with high value. And I think what we need to do is educate policymakers and explain that that's just not true. Thanks.
Were you able to hear that okay on the Zoom call?
Yeah, I think so. I don't know if anybody wants to jump in on that. If not, I'm happy to take at least part of that question.
Yeah, I think those are great points. I couldn't agree more about the human connection that's needed in the process of recovery. And the length of stay is frustratingly limited. The amount of time individuals are expected to understand their illness, their disease, what in some cases they may be given a prognosis that is far from where they see themselves being in a year, 2 years, 3 years, and perhaps even being introduced to a device that's going to constrain them even further. How do you balance between giving someone a tool that's going to help them be independent, but at the same time undermine their recovery process? Huge issues, huge challenges. And I can't agree more than you about this culture shift in how we stay connected with individuals that are part of this this ever-changing world of technologies, which do have a place in medicine. I do believe that they are extremely important. And again, it's the understanding the individual needs and carefully and methodically working as a partner with people that are using these tools to gain as much information we can in a feedback type of fashion, such that we can ensure that the needs are being met and changes are being made in a way that's going to be most efficient and most effective for each individual.
Yeah, I would agree with that, Randy. I kind of liken this conversation to what I think many people were internally debating post the acute phase of the pandemic, right? Are we going to go back to healthcare delivered in in-person encounters, or are we going to stay with telehealth as the primary delivery of care? And I think that it is less an either or conversation and more a both and conversation. I think that part of the nuance here is trying to structure things so that we can integrate both technological solutions and in-person care, human contact and in-person care in the way that makes sense for the recipient, right? I think that is always what is paramount. What are somebody's needs and how can we fill them through whatever resources we have at our disposal? So, yeah, I mentioned the fact that I do work in medical ethics, and this very conversation came up as the notion of autonomy became more and more paramount, that people should have rights to autonomous decision making in basically all aspects of the medical process. And that was leaving a lot of people feeling at a loss, right? Medical decision making is not always autonomous in nature. People need supports, people need to have guidance, people need to have human contact when it comes to really life-changing medical decisions. And I see that as kind of a parallel to this, right? We want to have a constellation of services and interventions that make sense for an individual and can fill whatever deficits can't be filled by the other. So I think it's a both and conversation rather than an either or.
Yeah, and I think let's think of an example where you're in the hospital or you're in a new facility and you're being asked the same questions over and over and over again. You've said how you were injured. This is your home. These are the number of stairs you have. This is where, nothing has changed. Is there a way to remove that from the quality time you have with your care provider, so that they can actually spend more quality time with you and your needs moving forward than re-documenting just to document and to create that paper trail of information that's already in the system, maybe 10 different ways across the last year. So in terms of technologies in healthcare and telehealth, there's the ways to reduce that burden on the care provider by asking those questions remotely or in a form that is not requiring use of a clinician's time to do data entry. Let that be taken care of by a device or a tool, and allow the real important human to human interaction and be much more substantive than in many cases they lose 10-15 minutes just by asking questions that have been asked many, many times.
Okay.
Anyway,
One thing I'll add is I brought it up before, but the hospital at home program, the reason why I think it's been so successful unanimously across those that have deployed it is nurses are getting into the home and they're literally spending an hour with the patient at a time. The patient's wearing, and I call the patient, really the individual's wearing what they want to wear, right? They're in their couch, they're in their chair that they're normally in, their dog is sitting on their lap. and they're going through and interacting with them. They're seeing their house, they're seeing how they live. And it's literally revived many of the nurses that I've worked with in just feeling confident about the direction of the industry, given all the challenges you described. I've worked at an EMR company, so I completely empathize with the idea of data management and spending time taking care of the computer, not the patient. And I think the technologies are getting better and more adaptive to how you want to take care of patients. But anybody who comes into a room that says this technology will solve this problem, you should run, right? Because it's the technology, it's the caregiver, it's the whole organizational process and operation that makes that work. But again, I would say this new wave of concierge care house calls has really shined a light on spending time with the individual patient. It's revived many of the nursing careers where they were at the wit's end of I don't like this profession anymore because I'm just inundated with patients coming to me. I'm trying to manage the computer, trying to manage them. I have about 15 minutes to get everything done, tracking everything down to I get to spend time and really get to know these individual patients. And then the telehealth component of that is when they're not in front of them, having a one-click access on a video screen to talk with that individual clinician or the team of clinicians taking care of them does bring another element of that relationship. And when used appropriately and correctly, it creates even a more intimate relationship with that patient and brings fulfillment on both sides of the equation. But a long way to go, but a lot of promise thus far.
All right, excellent. We have another question here.
We're gonna ask. All right. Hi, my name's Katie Carroll. Brooke, thank you so much for sharing about the sip and puff Morse code. I'm an amateur radio operator, so I found that fascinating. I'm going to share that with my club. So my question actually digs down a little bit deeper on the human connection and the role in humans in providing services and support. So in New York State, the Office for the Aging has deployed hundreds of this device called LEQ, which is an empathetic AI companion to older adults in New York State to combat social isolation and kind of help people manage their day-to-day. It does a lot, but I don't think it's unreasonable to think that for individuals, certain needs might be better met by a human in certain cases. We know that power wheelchair users can become eligible for seat elevation coverage through Medicare and Medicaid, but it's pretty clear that it can and will lead to a corresponding decrease in home care hours for individuals who get that benefit. So I'm thinking about this relationship, this conflict, this trade-off, this whatever between access to technology and then what is the consequence for accessing human support in services? So I guess if you could just do like a rapid fire, like one sentence, like what are each of you thinking about this relationship and what should people be concerned about thinking about? What's on your mind? Thank you.
I'm happy to go first. I think that the concerns that you raise are real and important and need to be addressed, right? But the only way to address them is by having these conversations, right? To think these things through from the get-go rather than, like I said before, like reactive in nature. I want to think these kinds of problems or unintended consequences, or even sometimes intended consequences out beforehand before we proceed down a certain path. I think none of us, nobody is looking for the creation of some kind of AI-driven robotic dystopia that's going to look to to keep us in some kind of home-based prison or anything like that. I think what we can create and should create, and in this conversation really can create, is a way to use technology to fill the very real gaps that exist when it comes to the provision of healthcare for people with disabilities and the achievement of healthcare equity. Rather, I think that is the intent. And if we think about the logical consequences or the potential unanticipated consequences beforehand, I think we could anticipate them and address them before they become real critical problems.
I agree with Brooke. I often, when I think about these technologies, I think about it in terms of dose, right? And then I think about the Goldilocks principle. Too much is bad. Too little is probably also in some ways a challenge. So understanding at what dose these tools and technologies can be used will be, it's going to be very important to make sure that these doses are catered to the individual and not to the masses. So with the LEQ, you know, it certainly shouldn't be, in my opinion, my humble opinion, a replacement of companionship with significant others. But if there's a way that it can serve as an adjuvant or a filler, and it provides some level of joy for individuals, then in some ways there's a win. So I think of a lot of these technologies in terms of that principle that Goldilocks taught us, that too much can be really, really bad, no matter what it is. And too little can also be not very helpful either. So.
Excellent.
Yeah, I think that's such a perfect question that really symbolizes choice. And also, I mean, Brooke, just what you were saying, this thing that we've gotten into our heads in the disability community of like, we've just been trained in our payment and our policy systems to really believe that we're undeserving. Like the idea that a technology would come in and replace human attendant or human interaction care, that is not a given. That's that's not a natural consequence of the increase of technology. That is a policy decision. Those were policymakers in their paternalism deciding that you can get one or the other. And this hasn't worked and we still can't figure it out. And here's this new technology system and we only have budget for one. So here's this. And we've seen that over and over again for decades. It happened with deinstitutionalization. Now we're going to close all the hospitals. Everybody's out in the streets. You start this massive homelessness and incarceration issue. If we think of this as a binary and we keep our policymakers in this idea that it's either one or the other, we're never going to get out of that thinking. It has to be choice. We have to expand the budgets. We have to push for that 90%. It is our right, not only the community integration, but that's the thing that's going to drive down costs, is that choice across that spectrum.
We have one more question before we wrap up.
Thanks, Matt. Thank you all for such a great conversation. You've been talking a lot about disability in the social context as well as in the medical context and how we live in both. Brooke, you touched on something earlier, and I just wanted to expand on that about embedding the lived experience into the development and co-developers. So I'm just wondering from all your perspectives of how we can look up the food chain when we're looking at regulatory science to embed the lived experience so we can change in policy changes. So for instance, earlier this month, the FDA put out a call out for members or nominations to the advisory council for their new digital health technologies advisory council. And they specifically did a call out for advocacy organization representatives. So just wanted to take it from those of you that are on the screen as well as those in the room of how we can look up the food chain so we can start these conversations with regulators, policymakers, payers, so we can change the system systemically.
I think that's a phenomenal question to end this session on, and I think it intersects perfectly with the entire purpose of this conference in particular, right? So organizations like United Spinal and others that work directly with community members, like, get in contact with them, partner with them, learn as much as you possibly can, right, in a way that's mutually beneficial, and get their voices in basically all aspects of innovation, right? So the Tech Access Council that Kai had referenced, right, this is a body of tech companies in the big tech space that are looking to make their technologies accessible, right? They the vision of the Tech Access Initiative was originally to have the Tech Access Council work directly with the Tech Access Group, right? People who care about this issue, wheelchair users who are extremely knowledgeable about technology and how they can be integrated into their lives, having this channel of communication, this conduit of knowledge exchange that I think is so very important. And that paradigm, I think, needs to be spread and shared across all disciplines, right? It doesn't just go for technology, it goes for how policy is enacted, right? So legislators need to have outreach and advocacy outreach to organizations like United Spinal, right? There is an entire division of United Spinal that works on advocacy and getting people to talk to legislators so that the policies that we enact are actually emblematic of the long instantiated disability mantra, nothing about us without us, right? Like, this is not impossible. It's just contrary to how we have constructed our thinking all this time, right? The very same way that people get advocacy done in any circle applies to people with disabilities. It's just a matter of finding where they are, learning from them, understanding that their experiences are valuable and that they can see the world from a unique vantage point that may have otherwise been missed without their inclusion, and wanting to have that inclusion as a part of an outcome. So I think it's just a matter of being proactive and thinking about things differently than we have historically thought about them.
Okay. All right, everyone, we have reached, we actually went a little over time. I want to thank all the panelists and Lewis and Brooke for putting together a wonderful workshop. There were some great questions. If you guys have further questions that you want to engage Brooke or Lewis or the panelists, please submit it electronically to us, and we will connect you with the individuals. I want to thank you, everyone. And, listen, we have, as Brooke had touched on, we have a whole advocacy department. It's, we need power in numbers. We need all of you to get involved to help drive those policies. So there isn't a, this or that there is ability for us users to have options, and, I like in person, but sometimes it's not convenient for someone like Brooke to get out. So to have those options, have that ability to do it. But the only way we're going to get there is with all you guys supporting our advocacy efforts. So please get involved, and, reach out. And when we send out policy calls, please sign on, do your part, and we can make big changes. So I want to thank you. We're going to take a break for lunch now. We will be reconvening in here at 1:30 back in this room. Oh, okay. Clinicians are in here. Tech access will be next door. So thank you, everyone. Enjoy your break, and thank you, Brooke, and the panel.
Thank you guys. Thank you so much.
Thank you, everyone.
This is incredible.
Thank you.
I will follow up with each of you after this.
Wonderful. Happy birthday.
And, reach out. And when we send out policy calls, please sign on, do your part, and we can make big changes. So I want to thank you. We're going to take a break for lunch now. We will be reconvening in here at 1:30 back in this room. Oh, okay. Clinicians are in here. Tech access will be next door. So thank you, everyone. Enjoy your break, and thank you, Brooke, and the panel.
Thank you guys. Thank you so much.
Thank you, everyone.
This is incredible.
Thank you.
I will follow up with each of you after this.
Wonderful. Happy birthday.
Thank you.